Hey everybody, welcome to Alabama EMS Challenge. We're in Dothan, Alabama today at the Wiregrass Public Safety Center. Thanks for the sponsors today. We got Survival Flight, Dothan Fire, Pilchers Ambulance, all pitched in to help sponsor the event down here. And we're lucky to have Dr. Hereford with us this morning. She's going to give us a lecture on sepsis.
As you said, I'm Dr. Hereford. I'm a second-year EM resident at UAB, and we're going to be talking about sepsis today. So what do we really want to get out of this lecture? What exactly sepsis is, the pathophys behind it, what are some common causes of sepsis, and identifying sepsis based on signs and symptoms and management and treatment of it too. So in our normal body, we'll always have some inflammation. If you get a scrape, a cut, something like that, it'll get inflamed. And the classic signs of inflammation, the pain, redness, heat or warmth, and some swelling to the area. But it's a localized and controlled spot. This is a normal response, and it's to help to eliminate the pathogen with restoration of homeostasis. That's the most important part. So it's not going anywhere else in the body, it's only right there. There's three main parts to inflammation, including vasodilation, which helps to increase the blood flow to the site. Then we have edema and vessel permeability, which allows the leukocytes and other molecules to leak out, and then tissue repair. And then the main thing is that there's a successful switch from this pro-inflammatory state to this pro-resolving state or anti-inflammatory state. So this is just kind of a picture of it. You can see right here is our infection. Just say that this vessel looks like it's gotten a little bit bigger. We have the and then everything comes back around, and then we're kind of going back to a normal homeostasis, what our body's normally at. So what's sepsis? It's disruption of the finely tuned immunological balance of inflammation and anti-inflammation. It's a response to an infection that becomes more generalized. So it's not only at the site of infection, it's kind of throughout the body and involves normal tissues at a distant site from that initial infection or injury. It's upregulation of pro and anti-inflammatory pathways that leads to a system-wide release of cytokines, mediators, and pathogen-related molecules. And this also can result in activation of coagulation and complement cascades that ultimately lead to DIC and things like that. Another way to put it, clinical syndrome characterized by systemic inflammation due to infection. And then it's a continuum of severity going from sepsis to septic shock and to multi-system organ failure. So just kind of another way of putting it in a picture-wise, here, normal infection, here's our little pathogens. These leukocytes and monocytes and stuff come through and help to clear this pathogen, and we have normal homeostasis. Nothing major is going on, it's only at the site. Here we have release of multiple other cytokines, and there's just this huge upregulation and huge inflammatory response that leads to dysregulation of our normal immune system. Another way to put it, just this is what our body should be doing. This is kind of upticks of all the things to help clear this infection, and it should kind of slowly taper off, and then during sepsis we'll stay down here and just continue to get worse and worse. So the definition of sepsis has changed multiple times since sepsis has been a thing. From 1991 to 2016, we kind of went by the STIRS definition, systemic inflammatory response syndrome, which we'll talk about a little bit more because it still is applicable today. In 2016, they changed it to the sepsis 3 definitions, with a definition of life-threatening organ dysfunction caused by a dysregulated host response to infection, with septic shock being a subset of sepsis in which profound circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than with sepsis alone. And then this can be clinically identified by a vasopressor requirement to maintain a map of 65 or more, and a lactate above 2 in the absence of hypovolemia. There's pretty much an international agreement on the technical definition of sepsis, but not on the clinical criteria for sepsis. So why did they come up with this new definition in 2016? New insights into the pathophys of sepsis. There's a lack of sensitivity and specificity of the SIRS criteria, which we're going to talk about, and it had like an excessive focus on inflammation. So this new sepsis 3 kind of emphasizes organ dysfunction in the setting of infection, which they've made this scoring system called a SOFA score, sequential organ failure assessment score, which is this. This is mainly meant for ICUs. Even in the ED, we won't have some of these from the get-go. Once we get some labs, we'll start getting some of this back, but especially for y'all in the field, the only things you'll have is like our cardiovascular, is their MAP above 70, and maybe like neurologic, their GCS. Besides that, all these are lab-based. And just point out, a score of 2 or more is associated with an increase in hospital mortality, and it's above 10%. Pretty high. So they came up with this thing called the Q-SOFA. It was introduced in 2016 also, and it's meant to be a rapid risk stratification of patients with suspected infection. It's neither very like unison with some other things that could be helpful. So the Q-SOFA includes altered mental status, respiratory rate, and systolic. Altered mental status, any GCS less than 15 is a point, respiratory rate 22 or above is a point, and a systolic of 100 or less is a point, and any score from 2 to 3 is associated with a 3 to 14-fold increase in hospital mortality. So this is the SIRS criteria that technically is not still used today, but I think is still very applicable. So we have 4 SIRS criteria: our heart rate above 90, respiratory rate above 20, or a PCO2 less than 32, temp less than 96.8 or above 100.4, with actually the hypothermia being worse, and a white count of less than 4,000 or above 12,000. For y'all in the field, you'll only have 3 of these maybe. Hopefully you all should have 2, the heart rate and the respiratory rate. I know sometimes we don't have working thermometers. But for this to be positive, 2 of the 4 have to be there. And then sepsis was 2 SIRS criteria plus the source of infection, which sometimes an infection source was never found, but they still had sepsis. And then severe sepsis, sepsis plus organ dysfunction, which could be classified by these right here: a lactate above 3, systolic less than 90, platelets less than 100,000, PT, T and INR that are elevated, T-bilirubin above 2, and creatinine above 2, and then if they're obviously intubated, that's another form of severe organ dysfunction. And then septic shock with severe sepsis plus persistent hypotension or lactate above 4. And for septic shock patients, there's like a mortality in excess of 40%. So this is just kind of looking at how the definition of sepsis and have changed over time. So like here, we still have our SIRS criteria. Now they are going with the SOFA score. But for the pre-hospital setting and even in the emergency department, we're not going to have this technical SOFA score for a while. So I think that the SIRS criteria is still very applicable along with the Q-SOFA, and that can help to guide our treatment plans. And then for the SEP over here, we'll kind of talk a little about this because what happens to them once they get to the ED, this is kind of what we follow in the emergency department. There are other early warning scores, including the NEWS and MUSE, National Early Warning Score, and then the Modified Early Warning Score. And they do have part of the Q-SOFA in there. So they have the respiratory rate, the systolic, and like the level of consciousness. And actually, in quite a few studies, the NEWS actually was found to be a better risk stratifier than the other scores that we've normally been using. So why do we care about sepsis? 1.7 million Americans develop sepsis in any given year. a lot of people. And then 49 million people worldwide are affected by sepsis every year. 350,000 adults with sepsis either die during hospitalization or are discharged to hospice. At least a third of U.S. hospital deaths are due to sepsis. And this accounts for 19.7% of all deaths worldwide. And those who survive sepsis are at an increased risk of negative health outcomes, including like new morbidities, inability to return to work, hospital readmissions, and death. And as we can see right there, up to 40% of patients are rehospitalized within 3 months of discharge. So once they get over sepsis, it's not like they're great, everything's perfect. There still is most likely going to be a problem after that. So Alabama has the second highest death rate due to sepsis in the nation. 18.6 deaths per 100,000 people in 2021. That's not a fun statistic to have. The only person worse than us or a state worse than us is Louisiana, shockingly. And then next, New Jersey at 17.2 and Kentucky at 16.9. Healthcare cost, it's a major cost to the healthcare system, estimated $62 billion annually in hospitalizations and skilled nursing care. And it's just like a very extensive and expensive resource-driven medical condition that hopefully if we are able to identify earlier, we can help to decrease the cost. So who's at risk? And this isn't necessarily like an all-inclusive list, but here's some of the important people. Elderly 65 and above. Death rates increased with age and were 5 times higher among adults above 85 compared to adults 65 to 74 years old. And there's multiple charts on the CDC website, but this is one of them, and you can see like how age increased sepsis death rates by quite a bit. People with weakened immune systems, including people who are on chemo, post-organ transplants, chronic steroid users, HIV/AIDS patients, they're definitely at risk. People with chronic medical conditions, including diabetes, kidney disease, cancer, lung disease, autoimmune conditions, and sickle cell patients. Indwelling lines, history of a PICC line, chronic Foley's, things like that. Compromised skin, people with ulcer, burns especially. Recent hospitalizations, recent severe illnesses, children less than 1. They'll also show a little different way of showing sepsis. Rural areas, and then males actually more than females. So there was this effort to improve sepsis or surviving sepsis in 2004. The Surviving Sepsis campaign was initiated. It kind of gives guidelines and it's updated every 4 years, most recently in 2021. In 2020, they finally made a dedicated pediatric guideline. And with the help of this campaign, sepsis-related deaths declined from 2000 to 2019. But since then, death rates have actually increased from 227 to 331 per 100,000 people. So it's still a very big problem today. And then the Centers for Medicare and Medicaid Services, CMS, developed this like Step 1 bundle to help early identify sepsis and things that need to be done within a specific time frame. So we'll talk about this. This is more when they get to the ED, but I want you to know exactly what happens once y'all bring them to us too. So some common causes of sepsis. Most common cause is bacterial, normally due to staph, E. coli, strep, or Klebsiella. You can also have viral, fungal, and parasitic. Fungal we especially think about in like immunocompromised patients, such as people on chemo or HIV, especially AIDS patients. And then common sites and types of infections, multiple different places listed different percentages, but it seems like the 2 most common for sure were respiratory with pneumonia being 40 to 50% of causes, and UTIs being about 25%. For the UTIs, E. coli was the #1 cause of those. And then GI, CNS, skin, and bacteremia, especially in IV drug users. So why do we care that y'all know what the signs and symptoms of sepsis are? Times of the essence. For every 1 hour in delayed treatment, mortality increases by 4 to 9%. That's a big jump. The biggest delay in treating sepsis is recognition, and then there's no single one test that will identify sepsis with 100% certainty. So it can be something that's hard to identify, but something that's very critical that we do. This is not an all-inclusive list of signs and symptoms, but I tried to be pretty thorough in what I thought could be. So hypothermia, hyperthermia, confusion, altered mental status, agitation, sleepiness, lethargy, especially in kids, just like a generalized feeling of being unwell, chest pain, shortness of breath, difficulty breathing, cough, nausea, vomiting, burning, increased urination, any UTI symptoms, especially if there's like a spot on the skin that's red, warm, and maybe like it's spreading up the arm, up the leg, or increasing in size, especially think about it then, and then a rash. So pretty much any symptom can be a sign or symptom of sepsis. So why does it matter? 87% of cases started before the patient was at the hospital, either with actual sepsis or the infection leading to sepsis was already there. Way I like to think about sepsis is like tacky, white hot, just from like a basic standpoint. When I first look at the computer, what's their heart rate, what's their respiratory rate, what's their temp, and then the hot is, or the white's their white blood count, which we'll have to get labs for. But that's just kind of every time I see a patient, that just runs through my mind. And those are technically SIRS criteria: heart rate, respiratory rate, temp, and then white count. So I think SIRS criteria are still very applicable, and I'm running through them constantly every patient I see. Look for SIRS and QSEFA criteria, obtain vitals, including temp if you have a working thermometer, and look for signs of shock, especially assessing cap refill in PEDS patients. Pre-hospital therapies, we'll go a little more into depth about these, but for airway and breathing, we like for them to be satting above 92%. If they have a history of COPD, then above 88% is fine for those patients. Circulation, get IVs if able, give IV fluids if hypotensive, vasopressors if indicated. If they're altered, make sure we get a glucose, make sure that they're not hypoglycemic, blood cultures if able, antibiotics, and then communicate that you're suspicious for sepsis very early. So does it matter what y'all do in the pre-hospital setting? Yes, it does. So this study was done in King County, Washington. It assessed around 45,000 adults who had EMS encounters. Around 1,300 of these people met criteria for severe sepsis on admission, and pre-hospital fluid administration was associated with decreased odds of in-hospital mortality. So it really does matter that we get fluids going and start treating sepsis very quickly and early. So for fluid resuscitation, based on the EMS protocol, I found 500 cc's to a liter of fluid was initially what you should start with. You can repeat that as needed. Anything that's in this green color is going to be pediatric dosing. So for PEDS patients, 20 cc's per kilogram for your fluid bolus. If they get to the hospital and you haven't started any fluids and they're in septic shock, our normal go-to is 30 cc's per kilogram. I'm just trying to be all-inclusive, tell you what we do also in the hospital. If there are any signs of volume overload, you see bilateral lower extremity pitting edema, they have crackles throughout their lungs, it looks like they might be volume overloaded, be cautious about how much fluid you are giving, because we might actually make it worse, especially if they have a history of heart failure, anything like that, okay? Normally, we do like to do balanced crystalloids, mainly LR and plasma light. I don't think y'all would have plasma light, but you might have LR compared to normal saline due to the possibility of hyperchloremia that some people feel like we need to treat, but there's no real big studies indicating that's actually the case. So what to do if they're hypotensive even after IV fluids? Our next thing is vasopressors. Hopefully at the point that y'all are in the bus and coming to the hospital that you don't even get to this point, but if you were to get to this point, one easy one is you can do push dose epi, 5 to 10 mics every 3 to 5 minutes. For PEDS patients, that's 1 mic per kilogram, up to 10 mics. You could start an infusion. And then Maybe neo, we have neo pushes in the hospital. We do 40 to 80 mics every 3 to 5 minutes for that. The only thing about this is if they are bradycardic, be careful because phenylephrine can also cause bradycardia. So that's one kind of a contraindication towards starting this. In the hospital for a patient in septic shock, our go-to first line is norepinephrine or levofeb, normally starting at 5 mics per minute. And if we had to choose a second one to go to after that, it's normally vasopressin. And then I know a lot of the people up in Birmingham carry dopamine, and they're very comfortable with that. There is a problem with dopamine. There is an increased risk for arrhythmias and an increased mortality compared to like norepinephrine in septic shock. So just kind of be aware of that. Hopefully you're not at this point either, but if you were, antibiotics, I know on our buses up there, the only 2 antibiotics they really carry is ceftriaxone and Ansef. You could go ahead and give that. We would prefer that you get blood cultures beforehand, but if the patient's crashing, the most important thing is possibly saving this patient, not getting our blood cultures. Then, especially if it's a kid who's hypotensive, ask parents about adrenal insufficiency. There are a lot of kids who have this, and if so, I would probably go ahead and, if they're hypotensive, have this history, go ahead and give them some hydrocortisone, with the dose being 2 mg per kg, IM or IV with a max dose of 100. So once they arrive to the emergency department, what do we do? So that SEP1 bundle that I talked about, we'll talk a little more about it, but that's this. We'll probably do a bedside POCUS ultrasound. We will look at the IVC, see how plump or flat it is, and take a look at the heart, see if it looks like they have maybe heart failure or decreased ejection fraction. And that can kind of also help to guide our fluid resuscitation. If they're having nausea, vomiting, anything like that, we're obviously going to scan their abdomen, so any imaging we need. Blood cultures, we'll start broad spectrum antibiotics and then get source control, whether that be removing the chronic indwelling line, the Foley, or talking to surgery because they have an abscess somewhere. So mainly for the ED, but just wanted y'all to be aware of what goes on. So this is kind of the step 1 requirements. We have severe sepsis still, septic shock, so still technically going by the STIRS criteria. We have this 3-hour bundle, which includes lactate, blood cultures, initial antibiotics. And if that initial lactate is elevated, then we'll have to repeat that and see if it's downtrending, uptrending, what's going on. Since they're not technically in septic shock, we don't have to do fluids at that time. But if they are, then we're doing this 30 cc's per kilogram unless there's some contraindication why we can't do that. Maybe they have heart failure, maybe their IVC is extremely plump, and we're going to worsen with this IV fluids. More for us, but just wanted y'all to be aware that we do have guidelines in the ED too. This is more that's this chart kind of in word form. So we get our lactate, our blood cultures, antibiotics, especially if they're in septic shock. We want to give these antibiotics within the first hour of arrival, if possible. Fluid bolus, vasopressors if needed, and then reassessment. We also get these other labs to assess for possible hypoperfusion of other organs or other organ damage, including CBC, mainly looking at that white count and platelets. CMP looking at bilirubin, coags looking at that PTT and INR, troponin seeing if they maybe have an NSTEMI due to hypoperfusion, ABG, UA, and the CRP and ProCal if wanting that. Normally we don't get that in the ED though. So antibiotics, we do empiric therapy covering gram-positive and gram-negatives. If they do have the history of cancer and they're on chemo, we might look into giving some like antifungals if they're concerned for that, but normally we don't do those. Normally starting with cefepime or Zosyn at UAB, we always do cefepime and vancomycin for our broad spectrum antibiotics. It depends on what hospital system you're at though. We try to be mindful of risk factors. So if we are concerned about MRSA, vancomycin definitely, there's others, dapto, linezolid. Pseudomonas is normally covered by our broad spectrum antibiotics, including cefepime and Zosyn, but there are others, carbapenems and ceftazidime if needed. If we are concerned about fungal infections, we can do mica or voriconazole. And then Legionella, which kind of presents as a weird type of pneumonia, we cover with macrolides and fluoroquinolines for those. So if a patient has continued hypotension and we've already given IV fluids, what are some other things that I'm thinking about? So I told you about adrenal insufficiency, especially in kids. Adults can have this too, especially if they're on chronic steroids, or maybe they've been kind of fighting this infection and they're just depleted. I'm thinking about giving those steroids, and that's 100 of hydrochloride for us. If I'm going into 2-pressor shock, I'm normally going to go ahead and give stress dose steroids. What about if initially our patient was getting a little bit better, and then now they're maybe getting a little hypotensive again? Going back through what I've already given to make sure that maybe they're not maybe they're having an anaphylactic reaction, like we were improving, now we're worsening again. These are just kind of rare scenarios, but in the hospital, if a patient was improving and then getting worse again, these are some things I start thinking about. Or if I'm on 2 to 3 pressors and they're still not improving, I'm like running down my list, what else could this be? For hypothyroidism, I would expect them to be hypotensive and also bradycardic, maybe have an altered mental status, which a bunch of those can match up with sepsis, except maybe the bradycardia. But what about if they're on a beta blocker? Then they can still be bradycardic and septic, but I normally will also order some thyroid labs on patients just to assess their thyroid function. Maybe it's an overdose on a beta blocker or something like that, and then maybe they're bleeding. So always asking any melena, any GI bleeding, something like that. Sepsis in children, know the vital signs in different age groups. I know it's a pain in the butt to remember all these. Easy way for a kid who's a year or older, 2 times the age plus 70 gives you the lower end of that systolic blood pressure that's acceptable. On kids, make sure we do the physical examination, assess the cap refill. If they have decreased cap refill, I'm getting a little more interested about what's going on, assessing their temperature if able. Hypotension normally presents pretty late. They'll have pretty big tachycardia initially, and that will go on for quite a bit, it seems like, and then once they're depleted, they just drop like a rock. So just be careful with that. And then a lot of the treatments are the same as adults. Normally in peds, instead of starting with like Levophed or norepinephrine, they seem to favor epi instead for their drips. And then neonates especially differ in the antibiotic choice. They'll get like ampicillin and ceftazidime instead of our cefepime and vanc. And being mindful of this adrenal insufficiency, as I said. And then they compensate well until they don't. Treatment goals for us, MAPs above 65, unless there's some other indication to have a different MAP goal. SCVO2 of about 70%, CVP 8 to 12. Urine output, we don't really monitor this in the ED, but up on the floor they definitely will, or in the ICU they will. They want 0.5 cc's per kilogram per hour. And then if that initial lactate is elevated, we would like to trend that lactate and try to get that decreasing, because that shows that our tissue is now perfusing better than it was initially. Rapid overview, just early recognition of sepsis, have it in the back of your mind. Like I always said, I run that through tachy, white, hot, heart rate, respiratory rate, white count, which y'all won't have, but temp, pulse ox, cardiac monitor, get IV access if we can, especially if we are concerned about sepsis, then they might be very flat, and I know it might be hard, so if you can't, that's okay, do the best you can do. If we can, that would be great. Fluid resuscitation, obtain blood cultures prior to antibiotics if you are giving them, if able. If not, that's fine. And then starting vasopressor therapy in adults if needed for a MAP above 65 and a normal blood pressure in children. And this was just kind of like the outline for sepsis that I found on the EMS website. Pretty much, I think, talked about all this. And as I said, be careful with the dopamine. I know sometimes that might be what y'all are all more comfortable with. And then with phenylephrine, actually not even listed on there, so perfect. But yeah. And then pitfalls to avoid. Just because they're non-tachycardic does not mean that they don't have sepsis. They could be on a medication that is blunting that response. So be very wary of that, especially I know in our Birmingham region, most of our patients probably are on some sort of beta blocker, calcium channel blocker, and these can be blunted. Altered mental status can be a sign of organ failure. Be wary of that. And then for us in the ED, sometimes we don't get a temp for a long time, so that's more for us. Yeah.
Very good. Thank you, Dr. Hereford. We got a couple of questions came in online. So the first one is, what are the thoughts on collection of blood cultures, pre-hospital lab collections prior to emergency department arrival, pros and cons? What about the issue of antibiotics before or after blood culture collection?
Yeah. So obviously being in the medical field, our biggest thing is do what's best for the patient. I know it would be pretty hard to obtain blood cultures en route to the hospital. Hopefully by the time that you're getting to that, you would be close enough. We would rather you get at least a blood culture, so we do have that. But if the patient's decompensating and you think it's sepsis, I would go ahead and give the antibiotic just to go ahead and get them covered. In the hospital, sometimes it happens to, we're having trouble getting access, trouble obtaining blood cultures, and sometimes it even happens in the hospital that antibiotics are given before blood cultures. That's just helps us to guide the pathway for treatment. In case it's special bug, wean off treatments. Maybe it's not MRSA, maybe we can come off the vein. But if we can't obtain that, it would be it.
Okay, very good.
Yeah, I'm gonna get in trouble making this statement out loud, but so my thoughts on the blood cultures is even in the ER, any nurses in here, nobody's gonna raise your hand. So good, smart people. Even in the hospital, in the ER, trying to draw blood cultures, a lot of times we get false positives. So for me as a clinician, I'm not a big blood culture guy. So if I think somebody is sick enough, septic, that I'm looking at them and I'm thinking their risk of dying in the next couple of hours because of this, I'm not drawing labs. I'm starting the fluid resuscitation and giving them their antibiotics, and then we get the blood cultures. I see so many dirty blood cultures collected in a hospital setting. I think that in the pre-hospital setting, I would suck at that job, drawing the blood, right? Just saying it like it is. When you think about the antibiotics, and the reason we brought this up, and we talked about this in super detail today, is because if you saw that map, we're number one, right? We're great at football, we're great at sepsis, we're great at crack, cocaine, right? Those are the three things we're good at in Alabama. So there you go. Somebody said roll tide. Is that what I heard up there? Maybe? So super important we recognize this, that sepsis is a spectrum from I have a small infection, I'm a little tachycardic, I feel bad, to holy crap, I'm altered and I have no radial pulse and just a carotid pulse. So if we don't recognize this early, people die. The state put in the protocol recently a sepsis plan and protocol. Y'all can carry 2 antibiotics. Anybody here carrying antibiotics in their trucks right now? So some places are, some places are not. My thoughts, for what it's worth, is that if you're carrying antibiotics in the field, that if you go to 1 or 2 hospitals routinely, that you let them know what's going on, so they're aware that we're going to jack up their blood cultures. They may not smile at you, but that's okay. They're a hospital. They're not going to smile at you no matter what you do, right? But that way they understand the rationale. Places that I'm working with, we give antibiotics for open fractures early. After we manage the ABCs, make sure there's not hemorrhagic shock, we do antibiotics for that early on, prevent long-term complications, infections with the bone and so forth. For sepsis, most of our time is spent recognizing the fact that that patient is critically ill, initiating IV access, starting fluid resuscitation, and then the pressors. And then we can get to the antibiotics. So the 2 antibiotics y'all can carry are Rocephin and Ancef, right? Those are, Ancef is great for bone and skin things. Rocephin is good for other things, but those are not the end-all be-all antibiotics, okay? I think it's more important for you guys to recognize sepsis and then say that when you get to the hospital. So give you a radio report, it should be like 18 seconds because we all have ADD. We're not going to listen to you long on the radio. But when you get there, as you're giving a report to that triage nurse or whoever you're giving a report to, you also smile, walk over and tap that doc. Hello, hey doc, hey, this guy's got sepsis. They're going to look at you like you're an idiot, but I'll bet you my $7 they get up and go see that patient, because sepsis is a catchphrase for our billers and for legal people, the attorneys. And so you're going to make them uncomfortable because they know they have a time metric they have to do. They have so many minutes to recognize sepsis, identify it, start antibiotics, and do things, or they get dinged. And in some places, those docs get dinged because they don't get reimbursed for that patient. So you're messing with their money. And I'm going to get in trouble saying that as well, probably. But my point is, if you have a patient that is sick that you think is septic or has sepsis, use that catchphrase, say it. If you think your patient at the hospital is having a STEMI or a heart attack, but the EKG doesn't read STEMI, but you're uncomfortable with it, tap that doc. Hey, I think this guy's having a STEMI. Again, it goes back to our metrics. Not that we're all bad people, but it's just those catchphrases make you hypotensive. Say, hey, this chick's got an ectopic. Catch up what I'm saying? Cool. When I think about fluid resuscitation, there are a lot of fluids we can use in the hospital. You guys got saline or LR. Every 10 years, it changes. We say saline is bad, then we say, nope, LR is bad, then we go to something else. Give them what you got. People say, what if they have sepsis and they're hypotensive and they also have congestive heart failure? Give them the fluids. Because the problem is, if you don't get that blood pressure up and restore circulation to the heart, the lungs, the brain, they're going to have a bad outcome. Now, if they're sitting upright, leaning forward, gurgling, they don't need a bunch of fluid. But I would bet my $7 again that you're not going to give them too much fluid in the field if they're hypotensive. When you think about pressor support, I think I'm talking too much. My coffee kicked in, didn't it? It's pretty cool. Yeah, I can tell. So fluid volume resuscitation, a quick leader wide open. If they're not responding to that, epi is a great drug, either push dose, or if you don't know how to make push dose or you're uncomfortable, no harm, no foul, make an epi drip real quick. Okay, a milligram of epi and 250 to saline, and you titrate to effect, and you calculate what that dose is as you're managing the patient, right? It's a titratable drug. Anybody carrying norepi or levofed, I know that's approved by the state, you can use same way. It is a titratable drug, right? If that doesn't work and all you have is dopamine, like you said, dopamine is, it is what it is, right? Risk to benefit, if your patient is tachycardic, hypotensive, you think they're in septic shock, and you don't treat this, they will die, okay? The immune response you talked about, the way I think about it being just a guy from the deep south is, I think of the immune response as like an allergic reaction without the rash or wheeze. So you get fluid shifts, you get altered mental status, you get low blood pressure. And how do we treat anaphylaxis in the field? Anybody know? Anybody care? Krispy Kreme donuts? Yes, 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 yes. I like you. Yeah, epi. So epi is a great drug for septic shock as well. Remember, it's a spectrum. And a lot of times you don't know what's going on with these people. So, for example, y'all have nursing homes in Dothan? Too many. You ever go there and check on patients there? All the time. Yes, sir. Correct. The good news is most of them have insurance, so that's good for your boss, right? So 70-year-old male with a Foley catheter in, who is heart rate in the, there you said it. He's septic. Very good, right? 70-year-old male with a Foley, and you show up to see him, I would bet you my cash he is septic. He might not be septic shock, but he's septic. So heart rate's 120, blood pressure is 110, sats are fine, breathing fast. We always get a glucose on people, it gives you a lot of information. Is it low? Is it high? Is anything else? It doesn't matter, right? So guy's got a glucose of 300. You look at him, you're going to think, old guy, Foley catheter, he's probably sepsis. So he gets IV access, he gets a little bit of fluids. If he is altered, now I can say he has end organ issues. Now he's in septic shock because he's now altered. Now I get it. He could be demented, right? Other issues. But I'm thinking about the things that kill people. So I'm going to say he's septic shock. So he gets aggressive fluid resuscitation. If I'm carrying antibiotics, I'm going to start my antibiotics on him. I'm going to tell the hospital what I've done. Okay. Does that make sense? Sort of, kind of? Good. All right. I saw a few people looking at me at least. That's good. What about if you got a 40-year-old guy with a, well, I won't do that story yet. I'm sorry. Can't give him too much fluids, and pressors, like you mentioned, the phenylephrine is great. If you're bradycardic, we're not using phenyl. I know that the flight guys do that. Nobody else is carrying, but phenylephrine, if your heart rate is slow, do not do that. You go on with levo or push dose epi or something else. The state says for your steroids, if they don't respond to some pressors, you can use cortisone, you can use solumedrol, you can use Dex, whatever you got. Now, obviously, if you're 15 minutes from a hospital, You recognize they're septic, start your fluids, start your antibiotics. If you got them, start your pressors and move to the hospital. If you're an hour and a half away from the hospital, then you got to start thinking out of the box. Start give them Solumedrol or Dex or whatever. Right.
Hey, Doc, what's the function of those steroids in the pathophys? Is it just if they're adrenal insufficient, or does it have a role even if they're adrenal normal?
I would say it has a role even if you're adrenal normal. How do you know in the field if somebody has adrenal insufficiency?
They tell you.
Right. They tell you. Yeah. Or they don't tell you. Right. So you just don't know. It's all risk to benefit. There's limited risk to giving somebody a steroid. The risk would be if they're a diabetic, you make their glucose go high, they go in diabetic ketoacidosis. That happens hours later. So you don't care. I don't care as an ER doctor. The other risk is they're pregnant and we're going to mess up the baby with steroids. If they're dying in front of me, I'm going to take that risk. Otherwise, I'm not going to do the steroids.
So we just had another question come in. Does your pressure selection change in the septic shock patient that has already shunted from peripheral circulation?
In the hospital, we always start levo first. That's our first line, no matter what really type of shock, even cardiogenic shock. Levo is still our go-to. So I don't think so.
Yeah, I agree. I think you use what you can use safely and more comfortable with. So if you're an agency, do y'all use push dose epi and down here in the field? Yeah. So if you're comfortable with push dose epi, I'm giving push dose epi. It's easy, it's quick, there's limited risk. Epi is already in your body, right? If you're not comfortable with push dose epi, I'm going to do an epi infusion. Okay. If you have norepi, like in the hospital, we use that all the time. So it's what you're comfortable with. What you don't want to do is you got somebody that's got a blood pressure of 70, they're altered, you think they're in septic shock, and this is your first time ever using push dose epi, and you draw it up wrong and you give the wrong dose, right? So use what you're comfortable with to salvage that patient.
So that ties into another question we got, which is realizing that a lot of services just carry dopamine, and that dopamine's dose dependent. Would you start off towards the higher end of the 20 mics per kilogram per minute? Because that's where we're looking at. Is the point the pressor action, the vasoconstriction? So you probably would start at the higher end if you know there's sepsis and vasodilation is the problem you're trying to fix.
Yeah, yeah. Who carries dopamine down here? Anybody? Everybody? Yeah, I like dopamine too. So the hospitals don't like it. There's good data that dopamine's not a great drug for a lot of these things that we use in the hospital. Dopamine is a great drug for someone who's in cardiogenic shock, the bradycardic, and the hypotensive, because it does both, right? But dopamine's still the good drug. We used it for years for hypotension, but it's a titratable drug. Do y'all have pre-mixed dopamine, or you have it in where you got to make it yourself? Mostly pre-mixed? Yeah, yeah. What's the dose of dopamine? Anybody want to guess and tell me what the dose of dopamine is? I heard somebody say something. 5 to 20, yeah. Do you count drops, or y'all have pumps? Drops, okay. So let me tell you how I titrate this. I take my bag of dopamine, I spike it, I prime the tubing, right? I hook it up to the patient port, I open it up. I look at the patient, I'm watching the patient, I'm doing other things. Maybe I'm taping my leads down, putting the defib pads on, I'm starting a second line, getting a better history, okay? Maybe I'm getting a load on the stretcher. I watch their heart rate. In the next couple of minutes, the heart rate is better if they were bradycardic. Or if I'm giving it for sepsis and the blood pressure is low, I'm going to recheck that blood pressure. I'm going to check perfusion again. All right. What's their radial pulse compared to the carotid pulse? All right. What's their distal cap refill? And I'm looking to see if that improves. If that improves, I smile and I break out my cheat sheet and I'm going to drop dopamine down to 20 mics per kilo per minute. That's the official max. If it doesn't get better, all right, I'm going to smile and drop it down to 20 mics per kilo per minute because they still need it, right? Does that make sense? It is a titratable drug. I'm not saying spike the bag of dopamine and give them the whole bag. I'm not saying that, let me be clear. But I am saying it's a titratable drug. What you don't do is you don't spike it, prime the fluid, hook it up, the port way far away from the patient, and start it at 5 mics per kilo per minute and go up every 5 minutes. Because at that point, what are we doing? We're delaying care. Does that make sense? Was that the right answer, or am I just too caffeinated?
No, I think you covered it. I like it. I would say that the dopamine's dose dependent on effect, and in the lower ranges, it's more has more to do with rate. Middle range is more to do with blood pressure, and upper range is more to do with vasoconstriction. I think that's the basis of that question: is would you start at like 20 since you're trying to get vasoconstriction.
Yeah, I would start higher rather than lower. Now, if this is somebody that's post-arrest, that's bradycardic and hypotensive, I'm going to titrate it the same way, but I'm going to watch that heart rate, and I don't want the heart rate to get too fast, and I'm probably going to start them back at 10 mics per kilo per minute, because that's kind of the max dose for heart rate. Okay? Yes, sir.
We got the tacky white lights, and they're full-blown ring failure. Fluids?
Yeah. Yeah.
Fluids first, fluids second.
Yes, sir. Yes, sir. And the problem is you can have some people that are going to have volume issues, right? So if you got a septic patient at that nursing home and they got a dialysis catheter Saturday, and you know they only do dialysis here Monday, Wednesday, and Friday, we're a day out from dialysis. If you give them fluid, they're not going to clear it. But what else can you do at that point, right? Now, I'm not going to give them 5 liters of fluid, but they're going to get 1 liter from me at some point real quick. And if that doesn't work, I may think in my mind, I'm going to move faster to my push dose epi, my epi infusion, my levo, or my dopamine on that patient, because I don't want to give them 30 cc's per kilo, especially if they're 150 kilos. That makes sense? Yeah. So fluid resuscitation, a lot of folks in the Deep South have heart failure, and that's fine. You can give them fluid. You don't want to give them fluid if they have pulmonary edema, which is they're going to be sitting up, gurgling, can't lay back, hypoxic. A big difference there.
So, hey, Doc, that kind of ties into, I think one of the things, well, I'll speak for myself. To me, the tricky part with sepsis is recognizing the sepsis. I mean, it's obvious in some patients, but a lot of patients, at least to me, it's not obvious that sepsis is the problem. So that ties into a question we have. Is there any guidance that's come out on qualitative capnography or end-tidal CO2 and SIRS sepsis guidelines, SEP1 and SOFA criteria? It seems like there should be a tie-in. You know, we did point-of-care lactate, blood lactate, as part of a study years ago, trying to triage people to the trauma system, and I often wondered why we didn't keep it, because it was cheap, it was fast, labs, and that would help too, right? I mean, I know lactate goes up for a lot of reasons, but wouldn't that kind of help us recognize sepsis?
Yes, I guess 2 points. The capnography, I don't know of any guidelines.
I don't either.
Yeah.
In all my research, I didn't see anything with that.
Yeah. So, yeah, I'm not sure. I know that as your perfusion decreases, your capnography is going to decrease because of poor perfusion to the lungs. The exception to that would be somebody who's metabolic acidotic and they're breathing fast to blow off that, but then the CO2 is going to decrease as well. So that's hard to say. For the lactic, we use lactic for a lot of things in the hospital. A lactic acid is produced when the body has to use anaerobic metabolism. And don't make me explain that, because I shouldn't say this out loud. I don't remember a lot of that stuff. Right. But the short version is, if you're hypotensive, you're not perfusing well, you build lactic up. But a lot of things cause that. So if I'm in septic shock, I would bet you my $7 you got a lactic acidosis, your lactate is high. If I go out and have 6 bush lights at Dega in 2 weeks, right, and I walk back to my camper, I would bet you my $7 I have a lactic build up because I had 6 bush lights and I just walked 500 yards. So lactic confirms the fact your patient could be sick. But if I'm looking at somebody and they're that 70-year-old at the nursing home with a Foley, they're altered, heart rate of 120, blood pressure of even 100, all right? If their lactic came back normal, I'm still concerned. I'm still going to manage them like they're in sepsis. Does that make sense?
It does. It just seems like it would be another tool in the toolkit to help us make clinical decisions.
Yeah.
In other words, if it wasn't obvious, there's no Foley, it's a 60-year-old with general illness, has been in bed for 3 days and their lactate's elevated.
Yeah.
That would, and maybe their blood pressure's soft, maybe it's 112 systolic.
Yeah. So I think, so my opinion, I think for folks that have long transports or for critical care guys, they're going to be going between hospitals, it's a reasonable thought. But for routine field care, I don't know. I'm not convinced yet, because I think that your assessment of that patient and your treatment is going to be the same. They're still going to get pre-oxygenation, good assessment. You can get a 12 lead because they're 70. Make sure you're not missing a STEMI or something weird, a hyperkalemia. You can give them IV fluids and resuscitate them. So.
Okay.
I can't say this either. In Alabama, you have to have a special license to do lab tests, and it costs a lot of money.
Yeah, I think that's probably the biggest objection is from the lab people.
Yeah.
All right, good questions, great discussions. Thank you for the lecture, Dr. Hereford. Anybody else in the room have any questions on the topic of sepsis? If not, we're going to take about a 5 or 10 minute break, stretch our legs, and we will be back with Dr. Ferguson.
Folks, welcome back to EMS Challenge. We are in Dothan. If you're in the area, come out. We'll be doing Skills Lab about 11:30 today. So for those of y'all not familiar with the EMS Challenge locally, or if you new online, we started this program back in 2014 to bring physician ed, con ed back to EMS. Years ago, when I was doing EMS, there seemed to be more physicians involved. That's kind of waned a little bit. So one of the goals at UAB in our department is to bring more physicians back into the EMS scope. So we're lucky enough to have leadership to support us, and we have our second year residents doing a month of EMS. The 30 residents can do electives with us. We have access. We're actually teaching a class to first year med students to do EMT training. And then the second year med students can do a kind of a transition to EMS medicine. Then we have an accredited fellowship. So these are docs that have done 3 years of ER after med school. They can come back and do a year with me and kind of sit for the boards for EMS. So we're trying to grow this for the state to get more physicians involved. So very supportive of that. Supportive of the Fire College for sponsoring EMS Challenge. Without them, we could not leave the Birmingham area. So thank you so much, Fire College, for doing that. And thanks for the folks having us down here today. I appreciate it. These are the goals of EMS Challenge. I show this every time. I'm not going to read this to you, but of who we are. EMS is a challenging world. You guys know this already. You're held to the same standard of care doing your procedures as I am. So when you intubate somebody in the field, if you're doing RSI, if you're putting a tourniquet on somebody, you're going to be held to the same standard that I am as a physician that works in the hospital. Not really fair to you guys because you don't have as many resources available to you. So that's one of the reasons we're doing this. So disclosures. Okay. I'm not a big researcher. This is one of my favorite graphs, researches I did. You can see that, and that keeps me working the ER nights and weekends. For your certificate, in the scan the QR code in front of you online. Chief's already put it in the chat box. If there's an issue, you can always email Alabama EMS Challenge at gmail.com to get your certificate. And don't forget, we do have a YouTube channel that is being updated, and we can give Con Ed for medics there. If you're live, we can give Con Ed to physicians, nurses, PAs, and EMS. So, updates, we'll be in Trussville in March, Enterprise, and the 20th. We're back at one of those. We're not Trussville, both of those. One of those is wrong. Well, and then we're in Winston County in May. We're up at the Rocket City EM Conference, and then up in Huntsville. And then we're going to do some presentations at the FDIC in Indianapolis this year. And CCTMC is going to be in Orange Beach for the flight guys. So it's in our backyard, nice national conference. So things I've been hitting every class for the past year. This is my goal for this academic year, is to talk about passive O2. Are y'all doing that down here in Dothan? So this is a cheap way to keep your people from becoming hypoxic. So we get a lot of ROSC back in our state. A lot of people get return spontaneous circulation, post-cardiac arrest. But what we're seeing is a lot of these folks end up having anoxic brain injury, so they don't survive neurologically. Obviously, there's several airways. All right, they can't bite you if they're faking it. If you put that in the nose, there's no teeth there. It gives you great access to the airway. And then if you only have one tank on scene, when you show up to an unresponsive person, I'm sliding the OPA in, I'm putting a nasal cannula on there, and I'm cranking it up to 15 liters. I know we all learned at EMT school or medic school or nursing school or med school that you have low flow and high flow oxygen. Nasal cannula is low flow, non-rebreather is high flow. That is BS. One of the benefits of the pandemic was we realized that nasal cannulas can really oxygenate people. So use it. I don't use a non-rebreather where I work now, and unless the nasal cannula does not work. So if I have a patient that's on a non-rebreather, they should have a nasal cannula under it on 15 liters, non-rebreather over that to fix the hypoxia. If they're alternate unresponsive, nasal trumpet, nasal cannula, 15 liters. So obviously if they're not breathing, we got to ventilate them. But if you have to kick the dog, if you have to roll them out of the street, if you have to move them down a couple steps, they're always getting oxygen even when you don't ventilate them.
okay? And we're going to play with this in the lab some today. There's no risk to this. I know American Heart talks about you don't want to give people oxygen if they don't need it. I agree with that. But I'll say if you're altered, unresponsive, unstable vital signs, if you look at a patient and your brain uses profanity and you think, oh, they're going to die, they get oxygen. Hypoxia kills people, all right? Now, you don't need to wear this for 8 hours. That's bad for you too. But if you got a patient on scene for 8 hours, something really bad's going on and we got other issues. So, are y'all using iGels, Kings, AirTrack? What are y'all using? Kings? Okay, fair enough. So I don't sell them. I'm an iGel fan because they're almost idiot-proof, okay? There's no balloon to inflate. The other cool thing about iGels is they have an O2 port. So you can pop that off and you can take your tubing from your ambu bag and plug it in there and put it on 15 liters and you're gonna flood the lungs with oxygen and you really increase oxygenation. And same point with this is, if I have to move that patient to roll them, to put them on the Lucas, to go down the steps, to kick the dog, the whatever, all right, if I'm not squeezing that bag, they're still getting oxygen. And again, these are almost idiot-proof. We'll play with some of these. I don't sell them. Kings work great as a biad as well. They just don't have that O2 port. There's some AirQ or AirTracks out there that some folks use. So, food for thought. The other thing I would stress, and I do this when I'm talking to the BREMS region, is if you place an ET tube on anyone, you have to document waveform capnography. My advice would be that in the narrative of your chart, you put place 7.5 ET tube. You can put, you saw it go through the cord, there's mist in the tube, there's no belly sound, all those normal things. But the last thing you put should be, I saw waveform capnography and at what number. If I'm doing a legal review of a chart and I'm going through that narrative and that's not there, it doesn't mean the tube was in the right place, but it makes me think, I got to go back and look through the data to see. If I see that in the narrative, then in my mind, airway was fine. That's not an issue in this patient, and you can move on. So food for thought, when you place a tube, airway confirmation, when you get to your end destination, whether it be at the hospital or where you cease resuscitation in the field, same thing. You know, arrived at hospital X, waveform capnography noted at 7. Tube was good when you got there. Nobody can argue with that. All right. Or work patient for 48 minutes in asystole, waveform capnography noted at 5. We cease resuscitations. We know the airway was fine. So food for thought. You can use capnography with the Kings or with the iGels. If you're placing one of those, use capnography as well. If you don't have capnography, you're not ventilating the patient. Think about doing something different. All right. I wanted to talk about hypertension some today. I knew that we had a lot of flight guys coming down and wanted to kind of talk about hypertensive emergencies. Just a lot of issues over that and the way we manage that in the hospital. So hypertension. Anybody ever seen a patient that has high blood pressure? Raise your hand. If you did not raise your hand, you probably have hypertension because you're dead, right? Yeah. We're in Alabama. We all have hypertension, diabetes, obesity. It's fantastic. Great from a doctor standpoint. I can bill you, right? But hypertension, as far as treatment in the field, should be very limited to a few things because treatment of hypertension can hurt people. So we talk about hypertensive emergencies. There are some relative numbers we think about, but some cases that we'll go through that kind of talk about the ones we want to manage and we don't manage. The state says you can carry the Betalol, you can carry nicardipine. Is anybody carrying those drugs? The Betalol, cool, perfect. So I'm glad I'm talking about this. So hypertension. Blood pressure equals cardiac output times vascular resistance, right? So if you increase that systemic vascular resistance, it makes it harder for the heart to pump blood to the organs that need it. And the heart, the kidney, the brain need blood supply. As we age, we get a higher blood pressure. As we have other health problems, our blood pressure goes up. And if we lower that blood pressure too fast or too much, you get ischemia, almost like you get anoxic brain injuries. All right. That was a loud sound. Okay. Okay, good. Yeah, now I'm hypertensive. Yeah. And so normal blood pressure is less than 120 over 80. Anybody here got that? I haven't had that in probably 40 something years, right? Even with meds, right? Elevated is anything over 120. I would argue that the majority of the patients I see in the ER have an elevated blood pressure. There's probably not many folks less than 120. And I would almost argue that if I have a 70-year-old in that nursing home with a Foley and their blood pressure is 110, that's probably hypotensive for them, relative hypotension, right? Cool. When you show up on scene with the lights and sirens going or the helicopter blaring, right? Most folks get excited, their heart rate goes up, the blood pressure goes up. So we're going to see elevated blood pressures in the ER in the field no matter what. So blood pressure is all relative to what your baseline. Based upon what we're looking at. So if I'm looking at that 70-year-old with the Foley and the blood pressure is 110, I'm thinking 70-year-old dude in a nursing home, he's probably normally hypertensive. So this is relative hypotension. Does that make sense? If I got a patient who has a blood pressure of 130 systolic and they got a big dialysis graft and they're huffing and puffing, relatively that's probably hypotensive because we know they have kidney disease and their blood pressure is always high. Okay? If I have a 60-year-old that's emaciated and weighs 50 kilograms and their blood pressure is 90 over 60, they're talking to me, smiling, laughing. Are they hypotensive? Probably not. That's probably okay for them. So blood pressure is all relative, okay? Cool. This is off the up-to-date, which is like a physician Google, right? It's med literature and talks about how we check blood pressures on people, the appropriate way to determine their blood pressure and the things you can and cannot do. And y'all can read that. I know in the field, y'all do this every day, right? They're going to sit in a chair. They can't be laying down, right? Most people are flopping around fighting you when you do a blood pressure. So all the data that looks at blood pressure is based upon people sitting in a chair, resting for 5 minutes, listening to Zen music, not smoking their weed, and that's not the patients we take care of. So do not get caught up on blood pressure numbers, all right? There's a lot of good data that says that lowering somebody's blood pressure, making them hypotensive is bad. We know that hypotension is trauma and bad, hypotension and sepsis is bad, hypotension and post-cardiac arrest is bad. So lowering blood pressure is bad for a patient sometimes. There's a big risk for decreasing perfusion to the brain, to the kidneys, to the heart. There's really no good data out there saying that we should be aggressive with this, right? So in the ER, what blood pressure, doc, do you get concerned about in the ER? If they have no complaints, they just show up and the nurse says, hey, Mr. Smith has a blood pressure of what? What will make you get up and go see them quickly? Yeah, exactly. So, 220, 230, something greater than 120 diastolic, I may get up and go see them a little bit faster, all right? Versus they say, hey, Mr. Smith is breathing 40 times a minute. I'm going to be up, putting my cigarette out and going to see him real quick. Okay, that was funny. I agree. So, what? Yeah. I'm gonna get him a menthol. That usually helps, right? So again, don't get caught up on numbers to a degree. Get caught up on assessment of your patient, what you think the normal blood pressure probably is-ish, what the patient looks like clinically, and what's going on, okay? Dude's got a blood pressure of 220 over 130, and his ankle is open and dislocated from dumping his bicycle. That seems appropriate. My blood pressure will be that high too. My heart rate's gonna be 140 and I'll be dropping inappropriate. Yeah, yeah, it was a Busch Light. That's expensive. You can't spell that. So the risk of lowering blood pressure is very high. There is some risk for not lowering it in some people, and we're gonna talk about which cases in which that matters. And when you can think about using your labetalol and your cardamine or whatever drug you got. But the risk of hurting somebody by lowering the blood pressure is pretty high. We kind of talked about the history in your physical kind of guides you into who you think has an issue with hypertension. I talk about STMs a lot with the EMS challenge, and it's the stuff that matters. So when you think about getting your history in a patient, you're not getting a history to check boxes for the chart. Your history guides how fast you move on your patient and what you think's going on with them. So the 40-year-old with chest pain, I'm gonna be doing my assessment. I'll be thinking about getting my vital signs, put them on the monitor during a 12 lead. And questions I may ask them, stuff that matters are, hey man, you ever had this chest pain before? Yes or no? If they say yes. You ever had a heart attack? They say yes. I'm going to be thinking, okay, he's 40, which is young as dirt, but he's got a history of heart disease. I'm going to move faster to get in my 12 lead. Everybody gets a 12 lead, everybody gets an assessment, but in my mind, I'm thinking, okay, I'm going to move a little bit faster, get my 12 lead. I may put up the pads on them, do something different, because that matters, okay? High cholesterol, don't care. You're in Alabama, you got it. Hypertension, don't care, we all got it. Diabetes, that's important. Folks that are diabetic have a higher risk for heart problems. So I ask them, do you take shots or pills? Okay, if it's shots, I assume it's insulin, and they're a higher risk. I know they're injectables that are not insulin, but I'm trying to keep it simple for my patients. And I'm using this to risk stratify them quickly. Shortness of breath, STMs, things that matter. Hey, I got a 30-year-old wheezing, working hard. You have a history of asthma. They say yes. I say, have you ever been admitted to the hospital for that? If they say yes, I know they have real disease. This is not some bronchitis or exercise flare. It's somebody that has significant disease. The next question I say is, you ever been put in the ICU? If they say yes, I know that they have critical disease, and they're going to get evaluated. They can get NEP treatments. Anybody with asthma would. But the patient that had been admitted before in ICU, I'm already thinking ahead. I'm thinking, yep, you're going to get those NEP treatments. I'm also breaking out the steroids. I'm going down to my second line. You probably get magnesium. And I'm also planning to move toward the hospital because I know they're super sick and have a risk of getting worse for me. Does that make sense? So that's the reason we get a history. We don't care about those other things, right? The other mnemonic I like is DFUP. Don't forget underlying physiology or pharmacology, right? And I say that in jest a little bit, but think about giving medications to people. So you got a patient having chest pain, that 40-year-old who knows he has heart disease, his blood pressure is 90/60, but we give nitro to patients with chest pain. Does he get nitro? The blood pressure of 90? No, why not? Yeah, because if you give it to him, he's going to drop his blood pressure even more, which can decrease perfusion to his heart and make him worse. And you go from a sick patient to an arrest patient, and it's really fun to work those. I like them too. But it's poor form to kill your patient, right? All right? What now? Yeah, it is frowned upon. Yes, right. It does. And you have to transport because they were alive when you got there. State law, right? The other thing is things like tourniquets, right? So we joke about tourniquets, or I joke about tourniquets some. So dude has a open dislocated ankle and blood is pouring out. He's diaphoretic, tachycardic, and he's altered. How do you manage that after you use profanity or you say cool? Do what to who? Remove that blood. What are you gonna do? Like put leeches on him? Oh, okay, all right. Remove that blood flow. I never heard of that. Yeah. Where do you work, sir? Okay. So yeah. So he gets a tourniquet, right? Right? But you got to think about anatomy and physiology. He doesn't get it on the lower leg because you have two bones. It's hard to push those bones together and stop that blood flow between them. So he gets it on the leg. If you want to go high and tight in the groin, great, do that. If you want to go just above the knee, that's fine too. There's only one bone there. He needs a tourniquet, right? What about the guy with a carotid mass on his neck from cancer, and he's got ate into his carotid and he's kind of squirting? How do you stop that blood? What did you say? Packet, very good. Yes. Does he get the? Do not put a tourniquet on there. You laugh, I laugh. Don't put a tourniquet on it. There's a reason it's up there. Yes, sir. Now, I've never seen the real tourniquets on the neck, but I have seen ACE wraps wrapped around pretty tight. You can't do that. So you pack it. Fingers in the hole, combat gauze, and you recognize, holy dirt, this is a bad wound. I'm moving toward the hospital as I'm doing this, right? Go. All right. Things that we do in the hospital to determine if somebody has in-organ damage and do we need to give them medicines to treat their blood pressure. This is what's recommended for whether you're in the hospital or in the field. And y'all can read these things. So chest x-ray, urinalysis, blood test, cardiac markers, CT imaging, or MRI. Y'all do any of those? No. Right. In some hospitals I work, I can't do anything but the blood test. What we can do is EKG. EKG gives you a lot of data. You can look for electrolyte disturbances. You can look, are they having a STEMI? And those folks, you got to think about managing hypertension. All right. So that's our screening tool to determine, for the most part, are we going to treat this hypertension, all right, with something other than the primary way you manage that issue. Things to be concerned about in managing blood pressure with acute head injury or trauma. What are the 3 things that kill people with head injuries? Subdurals, epidurals, subarachnoids. MCC guy hits a tree, not wearing a helmet. Now he's altered, confused, kind of seizing. We can do 3 things to prevent his head from getting worse. What 3 things? Yeah, so he needs oxygen, right? He gets passive O2. If there's no facial trauma, he gets a nasal trumpet. He gets O2 at 15 liters by nasal cannula. He gets oxygen. What else can we do? Yeah, okay, I can take that, yeah. So we don't want ice to be too high, but it's kind of hard to do that, right? So we can do that in the hospital. We can take a skull off, we'll put a drain in there. In the field, we prevent hypoxia. We also prevent hypotension because low blood pressure is bad for these folks, right? And the other thing we can do is we can make it where they don't vasoconstrict. We don't hyperventilate them. So if I'm going to intubate this guy, I don't breathe fast for him. If you blow off CO2, vasoconstriction decreases ICP, but decreases blood flow to the brain, so the brain still starts to die. So if somebody is hypertensive from a head injury, I'm happy, right? Because I know that there's something that's driving that brain to get perfused, right? So 3 things we do for head injuries: prevent hypoxia, prevent hypotension, right? And I would bet you my $7 in the next 5 to 10 years, we're going to see us start using low-dose epi, nor-epi, or push-epi in our blunt traumas that have head injuries to increase perfusion. We're not there yet. Don't do it now. I'm not saying that. Don't get me fired. But I think in the future we're going there. And then don't hyperventilate them. People say, what if they're having a herniation? I would say, well, they're probably going to die in the next few minutes. So if somebody herniates in the trauma bay, and I've got a neurosurgeon right there, if they're not moving toward the OR, taking the skull off, and they herniate, you die. So I'd rather you not hyperventilate and save the ones that we can. Cool. We'll talk about this in a few. We don't treat blood pressure. We don't lower it with labetalol, nicardipine, or anything. We want hypertension to save the brain. I'm sorry. Hypertension. Yeah, I like that. That's good. Yeah. Sweet. Focal findings that could be due in ischemic or hemorrhagic stroke. Sometimes we have to treat people's blood pressure for that. How do you know if somebody's having an ischemic stroke or hemorrhagic stroke? Who has a CT scan in their truck? Raise your hand. You don't. If you work in Memphis, you have one. Yes, right. I would say don't do that though. We don't know. We can be concerned, but we don't know. And the treatment of those two are completely different. Lowering blood pressure in ischemic stroke kills brain cells. Lowering blood pressure in ischemic and hemorrhagic strokes may help them, but definitely lowering in ischemic kills people, right? So you got this dude who's in his mid-60s, can't use the right side of his body, blood pressure is 210 over 120. He's within a 4-hour window, so he potentially could get thrombectomy. Blood pressure 220 over 120. Does he need blood pressure control? No. Perfect, because if it's hemorrhagic, right, he's hosed. I hate to say that out loud. Not a lot of things we can do for that. If it's ischemic, we can do things, but if we lower his blood pressure too soon without lysing him or going to interventional lab, we lose brain cells and bad things happen. Cool. The other thing that we see in the South that I see a lot is I've got people that have hypertension, diabetes, have kidney disease, and their baseline blood pressure is like 100 diastolic. Their baseline is like 190 over 100. And so maybe that's close to his normal, and he's having a stroke and he's tripping, so that's appropriate. And if I drop him down to 180 over 60 even, that's hypotensive to his normal hypertensive state. Does that make sense? All right, I'm gonna say that same statement like 1 billion times. Other things that can make you hypertensive that we can treat will be use of drugs. I know nobody does drugs in Dothan. This is the Bible Belt, right? Yeah. I think Birmingham's the meth belt sometimes. So we got a dude that's tripping. So 49-year-old male, no past medical history, sure. His bay called 911 because he's tripping. You get on scene and he's like tripping out. He complains of chest pain, shortness of breath, headache. He's mad at Nick Saban. Said he got some bad cocaine. He will relax for vital signs. Blood pressure is 220 over 120. Heart rate is 116. Breathing fast at 32 times a minute. He's sat in about 92%. Glucose is 116. Always get a glucose. Gives you a lot of information, right? And he's a little bit agitated. So does he need acute blood pressure management with labetalol, nicardipine, or something like that? Yes, no, maybe. That's high. My grandmama had blood pressure like that, and she had a stroke. That's high. Yeah, no, he's on coke, right? He doesn't need the beta law, right? So we do basic assessment. We got an AccuCheck. We're going to put him on the leads. We're going to look for end organ damage because he's an old guy, hypertensive with chest pain. So we look for end organ damage. Is he having a heart attack, a STEMI, or not having a STEMI, right? Cool. I'll let y'all look at that 12 lead. I'm kind of think about it. And I'm going to mention 12 leads just for a quick second. I do this about every month, every other month, but I got a couple guys online that love it when I do this every time. So this is for that guy. So when I look at 12 leads, I think they're too fast, too slow, or okay-ish. I'm going to go into a lot of detail. I want to talk more about hypertension, but EKGs are one of the best diagnosis tests we can use in the field. Gives you a lot of information. So this EKG, too fast, too slow, or okay? The rate's okay, right? So you can count it out. Looks about 300, 150, 170-ish, right? So I don't care if it's 70 or 90, it's okay-ish. I'm gonna look at injury patterns, 1, AVL, 5 and 6 for lateral damage, 2, 3 and AVF for inferior, V1 to V4 for ST elevation, which would be a septal or anterior infarct. And then you can also look there for posterior. So ST depression, T-wave inversion through here is a STEMI until proven otherwise by cardiology. At least in my practice, right? And the last place I look is AVR. If you're up in AVR and you're down anywhere else, so inferiorly or laterally, it makes you think either a left or right main, either STEMI or underlying heart disease, and the heart's got a strain pattern, stress. So things that can do that, massive hypertension in the setting of drugs can make you go up in AVR and down because your heart's strained. Sepsis with massive hypotension can make you go up in AVR and down laterally or inferiorly, okay? That's just a little schematic you can look at. It kind of gives you some ideas, STEMI or no STEMI. Remember, the machines don't read 12 leads well. You as a medic should be able to read a 12 lead. If you cannot, reach out. We can help with that, but you should be able to read your own 12 leads. So back to the dude that's tripping, the dude doing coke. So too fast, too slow, or okay? Yeah. So I use 50 to 150, so it's not less than 50, it's not more than 150, so rate's okay. All right, so I'm gonna start looking at injury patterns. I look at leads 1, AVL, 5 and 6. I look at, is there a pointer on this thing? Yeah. I look at 2, 3 and AVF, V1 through V4, and look at AVR. So what do y'all see? Nobody's gonna say anything. Good. Feel like I am at church, right? So I would say that we're up in AVR and I'm down laterally, right? So I'm down over here. So I'd say, could it be a STEMI? It's a STEMI equivalent-ish, but I would argue that dude's also done some coke, he's hypertensive and he's tripping. So this is probably a STEMI equivalent. So this is a sign that his heart's got a strain pattern, right? So this guy, we got to work with his blood pressure. His blood pressure is too high. His heart is showing us that it does not appreciate a blood pressure of 220 over 120. So how can we manage his blood pressure? What are we gonna do for him? So we got him on the 3 lead, got a 12 lead. He's sitting there, still kind of dancing in his brain, tachycardic, hypertensive, got IV access. What are we gonna do for him? Whisper in his ear, Nick Saban quit, right? That'll really get him mad. Yeah, thanks for laughing, Chief. Good, yeah. All right, so cocaine is a stimulant. It makes people ping, right? Sort of like meth. The way we treat that, because they're so hyperactive, we give them something to chillax them. We use benzos for that. So you got Versed, anybody carrying Ativan? You have Ativan, anybody carrying Valium still? Yes. So you got 3 choices. You got Versed, Ativan, or Valium. And what you're gonna see there is you give this medicine, it's gonna take away the effects of the cocaine, so he goes from tripping and pinging to chillax. Never fix that. So he doesn't need the beta-log, nicardipine, or the other medicines for blood pressure control. He needs management of the underlying problem, which is he did some coke. So this is a great person to get some Versed from you guys, all right? What about ketamine? Could you give him ketamine to slow him down? So state says you can, and I think that if he was kicking your butt and you got 4 law enforcement guys there and they've tased him twice and they got him kind of half handcuffed, yeah, he gets ketamine. He comes to the hospital still, but ketamine's not the first drug of choice for this dude because it's going to make him tachycardic and hypertensive more. So he needs Versed, Valium, Ativan. This might be the one that you have to call med control real quick. Hey doc, got a 49-year-old guy, I've been doing some coke, he's hypertensive, tachycardic, kind of agitated, can't give him ketamine. I'm gonna give him 8 of Versed. Thank you, sir. Hang up. Right? You got your orders, you talk fast, they won't answer you. Right? For the critical care medics, this is the guy that if you're gonna fly this guy, ain't no way I'm putting this guy in a helicopter if he's been doing some coke. He may lose his stuff en route. So he gets either Versed, Ativan, or Valium. Then he gets some other drugs to sedate him, etomidate, more Versed. By more, I mean 8, 10, 12, right? And then you sedate him, you intubate him. At the hospital, I'll put him down with benzos, and I use a drug called propofol or Michael Jackson juice, right? And that works pretty good too. But he does not need the Betalol or blood pressure medicines. He needs treatment of an underlying problem. So I give this guy the Betalol, right? I'm gonna slow his blood pressure down, heart rate down for a few minutes, but he's still pinging on the coke. Doesn't fix the problem. Same dude, but this is a different EKG for him. So this is his EKG. What do y'all see there? Too fast, too slow, or okay? Rates okay? Look for injury patterns. And what do y'all see? Who says STEMI? Raise your hand. Who says no STEMI? Good, everybody's awake. Good, yeah. So he's having a STEMI. So now, how do I manage his blood pressure? He still gets Versed, Ativan, or Valium, because he did some coke, all right? But now he also goes down, and I'm thinking, all right, either this is all from the fact that his blood pressure is 220 over 120, or could this 49-year-old guy that does cocaine have heart problems? He could. So he also goes down our pathway to treat for STEMIs. So I'm going to be pushing some Versed or some Ativan or some Valium. I'm also going to be giving him a quick drug. What's the first other drug I want to give him? It goes in his mouth hole? Nope. Aspirin. Yeah. He gets aspirin, right? So we want to thin his blood so that clot doesn't get bigger. He gets aspirin. And then after that, if his blood pressure is still fine, he gets the aspirin, he gets the benzos, then he's getting the nitro. He also gets pre-oxygenation, a couple liters of O2. He was already breathing fast. All right, we call it pre-oxygenation because the risk of having a cardiac event with the STEMI is pretty high. Okay, and that way the hospital and AHA doesn't fuss at us when we say it that way. All right, and he gets defib pads because they're prone to having dysrhythmias. And then he starts moving to the hospital. So my mnemonic, there are a lot of mnemonics out there for chest pain. There's the Mona, the Fona. If you've watched me before, I have SIT, which stands for suspect, identify, and treat, and then transport. And then my sarcasm is the rest of my mnemonic is AIV, NRT, LPOM, because that one's much easier to remember than Mona or Fona, right? And do y'all know what the AIV, NRT, LPOM stands for treatment purposes? Nobody knows that one? God, that's aspirin, right? First thing, most important drug, prevent the problem from getting worse. IV access, so if they go into cardiac arrest, we have access to give them things. Nitro, all right? What is RTLP? You may know what that stands for, besides Chief Ward. That's ride to lightning pads. They get defib pads. What kills you in the first 4 hours of a STEMI is at the same time. And then morphine. Why would I give this dude morphine? Yeah, or more importantly, not so much pain, vasodilation, lowers the blood pressure, right? Cool. Yeah, sweet. All right. So I'm not sure what that picture's for. I guess I'm making fun of my own mnemonic there. All right. So we kind of covered drugs that can produce a hyperergenic state, talked about chest pain, but you see there was no mention of giving them labetalol, nicardipine, any of the other blood pressure medicines that we talk about, whether it be for the guys the pre-hospital carry or the drugs that you can get at a hospital. Next case, you got a young guy, been drinking since David left Van Halen, if anybody knows what that means. Anybody know what year? You know what year you get a challenge coin? What year did David Lee Roth leave Van Halen? Anybody know? Nobody wants a challenge coin. Not even close. All right, we'll move on. What'd you say? Oh my God. Anyway, his drinking got worse when Van Halen came back in like 2013, right? But he said, I'm quitting cold turkey. I'm done. You get on scene. The girlfriend said that he may have had a seizure. He's now confused. You talk to the guy. He's tremulous. He's kind of babbling. Blood pressure is 225 over something, the EMT says. What are we going to do with this guy? What's going on and what we're going to do? Detox, straight to detox. Yeah. Good luck finding a detox in the state of Alabama. Yeah. Get the man, I like that. Get that man a beer. Right. So what's going on? He's got alcohol withdrawal. I can't read that. Oh, yeah. Very good. You're correct. It's like, I can't see. Yeah. Yes. 85. Good. Okay. You get a coin. So this guy's having alcohol withdrawals, and that is fatal. So withdrawing from alcohol or benzos will kill people. Being drunk sometimes can, but withdrawing from it definitely can kill you if we don't recognize it and treat it. If I give this guy a beta blocker or something to lower his heart rate and his blood pressure, and I don't treat the underlying problem, he will die. I'll bet you my $7 and his challenge coin, he will die. Cool. When you think about alcohol, it depresses the CNS. You think about the body's response to alcohol is alcohol depresses everything. So the body's response is to push up harder, to increase sympathetic response, to make you more tachycardic and hypertensive. So as you drink more and more, your body has a resistance to that and pushes up. When you take away that alcohol, now the body goes crazy. The body's used to having to fight against that depressant. So they become hypertensive, tachycardic, they have seizures, they have strokes, they have brain bleeds, all kind of bad things, right? And we treat them the same way we do cocaine stuff. We treat them with the benzos, Versed, Valium, Ativan, all right? Or he said alcohol, okay? So you don't have access to that. This is your buddy. You're at the deer camp for the weekend, and your buddy seizes. When he wakes up, you sit him up, go get him some whiskey. Get him cheap stuff, all right? Like Seagram's VO or something. Don't give him the good stuff. But he needs either alcohol to depress the CNS, or he needs benzos. In the hospital, we use phenobarb a lot, especially because there's an Ativan shortage. If I'm intubating this guy, once he gets benzos from me, I'm gonna give him enough propofol to kill 3 Michael Jacksons. And then, like you said, alcohol works as well. You know, pull over to ABC store, that one in the circle out there next to the hotel that I stayed at last night, they got alcohol there too. Sweet. Next case, 56-year-old male, history of hypertension because he's in Alabama, short of breath, breathing 32 times a minute, hypoxic, heart rate's in the 110s, blood pressure is 220 over 115. He's awake, alert, he's anxious, but he's sitting up, leaning forward, huffing and puffing. His legs are swollen. What's going on with this guy? Yeah, I would say use the phrase not CHF. I'll say he has pulmonary edema. A lot of folks have CHF but don't have pulmonary problems. And I deeply care that people have CHF. I'm not going to do anything about it. I care about the pulmonary edema, right? So he's fluid volume overloaded, right? So now this blood pressure at 220 over 115 makes me uncomfortable. Now I got to fix that, right? But I'm not going to fix it with beta blockers. I'm going to fix it with this mnemonic, which is easier than the SIT, AIV, LNRPQ, whatever I said, right? This is LMNOP, and you treat it backwards. So how do you treat pulmonary edema? What's the first thing you do when you get that guy? I said, no, sit him up. Yeah, the P is position and pressure, right? So I'm going to sit him up, all right? I'm not going to put him on my stretcher and lay him back flat. What happens? He gurgles, he dies, right? When you get to the hospital, you can see us smart doctors take your patient that you got sit up right, we move him to our stretcher, and we lay him flat and say, hold still, we got to weigh you on this bed. And they're like gurgling and twitching and dying. So you sit them up, right? And they get positive pressure ventilation, CPAP or BiPAP. If you got a vent on your truck, BiPAP. If you don't, it's CPAP. That does two things. CPAP increases the pressure inside your chest. And remember, blood comes back to the heart, right? So the increase the pressure here decreases blood return. So now the heart has more chance to pump the fluid out of the lungs, right? So CPAP decreases blood pressure. All right, positioning makes the top part of the lungs where you can breathe for them, where they can get air in, and you lower that blood pressure with CPAP, not the Betalol, not clozapine, none of those drugs, but position and pressure. Obviously, they get oxygen, they get nitro because it lowers the blood pressure, decreases preload. They get morphine because now they go from short of breath and feeling bad to high as a kite and don't care, and it lowers the blood pressure. And the last thing I'm going to give them is Lasix. Okay? If I got a short transport, I'm not going to give them Lasix. Do I give people Lasix in the ER? Yes, I do. And I do it because if I don't give them a dose of Lasix and we admit them to the hospital and they don't get a dose of Lasix in the first 24 hours, you cannot bill their insurance for CHF. Nah, I shouldn't say that out loud either, should I? Sorry. I was joking. That's not why I do it. But most people you can fix their pulmonary edema with position pressure, oxygen, nitro, and then morphine. And not even going to the morphine. CPAP, BiPAP is a great way. All right? What are you going to do if you have to intubate this guy? So you got him on CPAP, he's sitting there, now he's altered, head bobbing, and he's not breathing good anymore, right? And it's CPAP, so he's got to ventilate himself. How are you going to position this guy to intubate him? Ramp him up, yeah. I'm going to leave him on that CPAP, all right? As long as I can, I'm going to sit him up and get my drugs ready, and once I put him down with a sedative and I push my paralytic, then I'm going to lay him back just enough to get my blade in. Or if I'm really cool, I can do it from the front if I got a cool video scope. But what I'm not going to do is I'm not going to take the CPAP off, put a non-rebreather on him, lay him flat, wait 6 minutes to blow off the nitrogen and oxygenate him, and then intubate him. Okay? And if I got somebody on CPAP, I got a nasal cannula under that, and it's on 15 liters. My second tank goes to the CPAP, and I would bet you my $7 I can oxygenate him. If I'm doing BiPAP, first tank, nasal cannula in the nose hole, 15 liters. Second tanks goes to the BiPAP. So congestive heart failure, pulmonary edema, we treat that hypertension with nitro, CPAP, and aggressive airway management if we need to. We don't do labetalol, nicardipine, clopidogrel. That's not good. 64-year-old unresponsive. Family called 911. He had a headache, left side of weakness. You get there, he is gazing to the right, kind of lip smacking, but doesn't do anything else. Eyes wide open. Okay, heart rate's in the 90s. Blood pressure is 220/130, breathing about 8 times a minute, a little bit hypoxic. Glucose is 316. Always get a glucose. If it reads low, you can fix the problem. If it reads high, you know the problem's probably electrolytes or DKA or something bad. Okay, everything in the middle, you just say roll tide. So, this guy having a stroke? He could be. Yeah. Family kind of makes it sound like he's having a stroke, right? So you can put him in the stroke system if you want to, but remember we use the EMSA scale now. To actually put somebody in the EMSA scale, they have to be awake and talk to you and participate in the exam. So you're not going to be able to get an EMSA score on that dude because he's not talking to you. All right? You can put him in the stroke system. He'll be under EMT discretion. That's fantastic. All right? The rules of the EMSA, they got to be able to participate. Okay? If they're alert or verbal, you can EMSA them. If they're a P or a U, you can't EMSA them. He could still be having a stroke. You think it's ischemic or hemorrhagic if he is? Probably hemorrhagic. Can't fix. I think other issues, lights, drug use. The other big issue is airway management for these guys because if he got bad blood in his head, we got to prevent hypoxia. We got to manage his blood pressure, prevent hypotension, and we got to make sure he's ventilated well and doesn't blow off his CO2 like we talked about. The other thing I mentioned this is because y'all can do thrombectomies in Dothan, right? Yep. Pretty cool. The other place I think that's close is maybe Baptist South. I'm not sure if y'all go to Florida for that yet, do you? Baptist East? Oh, sweet. Okay. Cool. So when you think about doing your EMSA scales, if you got somebody within a 3.5 hour window and they're close and their EMSA scale is 4 or greater, you want to go to that thrombectomy center. If they're altered, seizing, completely unresponsive, you can't do an EMSA scale. Right? So if we give them an EMSA number and we fill up that thrombectomy center with other neurological emergencies, all right, we're going to hose that hospital where they can't do thrombectomies. So food for thought on that. So what are we going to do for this guy? He's gazing to the right, lip smacking, a little bit hypertensive. What are we going to do for this guy? How do we manage his blood pressure? What are we going to do? Yeah. O2, I'm going to sit him up, all right? I'm going to give him nasal cannula O2, maybe do a nasal trumpet in him. I'm going to assist his ventilations if he lets me. I'm going to help him breathe, right? If I do positive pressure ventilation, that's going to help that, all right? If he starts seizing, I'm going to give him some benzos. That may help with the blood pressure as well. If you think his lip smacking is a seizure, Give him a little benzos now. All right? Manage his airway. He's going to get some IV fluids. Yeah, but he's hypertensive. Yeah, but he's also got a glucose of 316, so he gets IV fluids. What he doesn't get is he doesn't get labetalol, clozapine, or anything like that. So when you think about end organ damage and hypertension in the heart, we're looking for STEMIs. You can't look for the end STEMIs, the ones that don't have EKG changes without labs, but STEMIs, right? We treat with nitro, aspirin. In the hospital, we treat with anticoagulation or thrombolytics. We've got the cath lab. The kidneys, end organ kidney problems, hypertension, you can't tell in the field. You're not going to tell, can they make urine, can they pee, what's their kidney function? You can't do that. So that one really doesn't matter to you. And to me, for the most part, in the ER, because I can't do it without labs either, right? Vascular issues, we think about aortic dissection, and how you diagnose that? CT scans, right? Cool. Got here. So things we may treat blood pressure or hypertension for. Ischemic strokes that we give lytics to when the blood pressure down less than 180 over 90. Some places a little bit more, a little bit less. But the only time we do that is after we get that CT scan. Okay. The other thing I get concerned about in the field is a lot of times you got somebody seasoned or moving around, my blood pressure cuffs don't work well, you get a bad number. It's like that number. Don't trust the machines. Acute aortic dissection, those guys, we want to drop their blood pressure as low as we can and keep them awake. We drop their heart rate and the blood pressure. But for the guys doing 911 calls, you're not going to know if somebody has an acute aortic dissection. You can suspect it, but you're not going to know until you get imaging. For the guys that do transport and flight, if you're transporting somebody with an acute aortic dissection, yeah, they're going to be on the labetalol, maybe an esmolol drip or something else, but we have definitive objective data to show that. And then head bleeds. Depending on which neurosurgeon or neurology team you're working with, they have different numbers we want to get them to. But you got to get a scan for that. All right. The other problem is most of these people end up getting intubated and getting airway control when we can manage the blood pressure with narcotics, benzos, or sedatives. What we don't want to do in the strokes is overshoot blood pressure control. So the guy having an ischemic stroke, blood pressure 220 over 110, I give him the labetalol because he's going to go to the cath lab to get a thrombectomy, and now his blood pressure is 120 over 40. Now what do? Now I got a guy with a stroke that I'm giving blood pressure medicine to increase his blood pressure. Poor form. No, that just says you got to have a CAT scan to figure those out. Yeah. Sorry, I like cats. I did, I know, I reach for a lot of things, but it's all about me, sir, right? For the lungs, in the end organs is pulmonary edema. We decrease the preload with nitro, we do positive pressure ventilation, that fixes the blood pressure, no need for labetalol. Now, if I got somebody that's altered, confused, their CT scan is normal, they're not having an ischemic or hemorrhagic stroke, blood pressure is still 220 over 140, they don't have drugs on board, I've managed their airway with positive pressure ventilation, I've given them more benzos than you can imagine, and they're still hypertensive and confused. Now I'm thinking this is end organ CNS, right? Or we call PRESS. And yes, now I'm gonna give them labetalol, esmolol, drugs for blood pressure control. But that's after everything else we talked about, after imaging in labs, which you guys don't have access to. Rapid and aggressive therapy to lower blood pressure kills people. Places that I work, we don't use labetalol because my concern will be that someone has a blood pressure of 240 over 160, give a little labetalol, and actually the blood pressure was artifactual, and now I got somebody having a stroke that's a hypotensive. There's a big risk to antihypertensives if you don't have those diagnostic tools like we have in the ER. I'm not saying don't do it. Actually, I am saying don't do it, but talk to your medical director about that. But lowering blood pressure in people is bad, doing it acutely. Long term, yes. You don't want a blood pressure of 220 over 110 for 6 months is bad for you. But for you guys and for me, you need to watch how we manage his blood pressure. And that's their signs of end organ damage. And then there's one more thing that I wanted to mention about end organ damage and hypertension for the flight guys or even the folks that intubate somebody in the field in the post-resuscitation. If they're hypertensive post-intubation, okay, and you don't think they're having a stroke, you can control their hypertension post-intubation with drugs, Versed, ketamine, fentanyl. There's a state protocol that says you can sedate them like crazy. and that usually manages the blood pressure, and there's no need for labetalol. So, snapshot from our protocols, things you can do, but just because you can do it doesn't mean you should. So, my advice, if you're an agency carrying these antihypertensive medications, if you're a flight crew, talk to your medical director, fill out what they want to be done with this, but be very aware that lowering somebody's blood pressure pre-hospital or even and I know that Chief Ward's probably sick of seeing it, but I got 3 rules that I try to live by. Sometimes I don't accomplish it, but don't kill people in your job. As a medic, as an EMT, as an advanced EMT, you have access to things that can save lives, or if you use wrongly, can kill them, all right? Try and help people. A lot of things I can't fix. If you got blood in your head, I cannot take you to the OR and fix that. If I take you to the OR, you will die. I'll bet my entire cash allowance on that, okay? But I can recognize the fact, holy crap, you got a head bleed. I can manage those 3 things we talked about, and I can find a surgeon on the phone to get you to where it is, okay? I'm gonna go home with a clear conscience, all right? So that means that every day I run through cases in my mind, I think about things, I review the cases that I do, I'm trying to learn and grow, because the work that you do, people actually can live or die based upon that. It's corny, but it's true. If you look at these slides, the pictures here, you see there's a doctor and an EMT. You see the difference in those two? Anybody notice the difference there? The doctor has bigger arms. I just want to point that out. The doctor has bigger arms, okay? If you look at this slide, so American healthcare is whack right now. So we expect EMS to do the same job that we do in the hospital with less resources, less training, less foundational knowledge. So we as healthcare should be these people, because the work that you guys do is a lot more dangerous, more complicated than we do in the hospital sometimes. So, and that's just more inappropriate humor. Questions, comments, statements within reason. I know I talked way too fast. Oh, yes, question. Yes, sir.
The only question I have, so say you're taking a critical patient, say it's Birmingham or Mobile, why does it always seem like the hospitals result to propofol drips? Because like, I've personally seen it where, say the patient's on a vent and they'll wake up. So like, what can you give them that's like, I guess more like a sedative, you know, to like make them withstand the transport? I mean, there's a lot of bumps in the roads. I mean, you can hit them slow or fast and they wake up. Like, it just makes the person in the back, their job is like
A lot harder.
Yeah.
So propofol is a great drug for long-term sedation of ventilated patients. I will advise that if the patient is not intubated, do not transport them with propofol drip, that'll get you in trouble. Again, just make that statement, right? So you can always adjust the dose of propofol, but you're gonna have to have that physician before you leave write that one for you. And you can't titrate it, right? The risk of propofol is if they are volume depleted, they get hypertensive level pretty quick. So you gotta make sure
This is not, propofol is not good for traumatic, hypovolemic shock, those kind of things, or sepsis, because you got to keep their fluids going. So I would recommend either increasing that propofol drip or getting some PRNs to use fentanyl or Versed in addition to that. And actually, there's a protocol in our state that says that if someone's intubated, you can give them, well, I don't remember the exact doses, but there's a lot of fentanyl, a lot of Versed you can do before you have to call med control for. And I think some push doses on top of the propofol does pretty good. What do you think, Doc? I mean, I know we use a lot of propofol in the hospital, but we're doing other things too.
Yeah. I feel like it's what we mainly do.
Yeah, we use a lot.
Fentanyl for that. Now, obviously, if it was like a post-arrest patient, they got a bunch of Narcan in that arrest, which is probably crazy, then you want to use fentanyl, you use Versed. But just remember that propofol will drop your blood pressure. So any drug that you give that lowers blood pressure, be advised that you got to watch for that. Other questions, comments, statements within reason?
Hey, Doc, we had one come in to me. What about the patient with pulmonary edema from missing several dialysis appointments? Is beta blockers or calcium channel blocker appropriate for those people?
I would not, no, would not. Again, the main, whether it's from fluid in the lungs, from congestive heart failure, right, acute pulmonary edema, or it's from volume overload, from lack of dialysis, end-stage renal disease, managed the same way. It's upright position, positive pressure ventilation, decrease the preload. The scary thing is, what do you do if you got that guy that is in frank pulmonary edema, hypoxic, working hard, and his blood pressure is 90? Yeah, you put him on positive pressure ventilation, you can drop his blood pressure. You can't give him nitro. He's already volume up. That's a scary patient, right? But no, the treatment's the same way. Obviously, I would not give Lasix to somebody on dialysis because Lasix makes you pee. If you're on dialysis, you probably do not pee very well.
So really what you're saying, I guess, it's confusing, I think, to a lot of people getting some traffic. And the confusion part is and I need you to tell me because I don't need to hear it from me, but are you telling us that there's really not such a thing as hypertensive crisis? Because everything we went through.
Correct.
Is you're treating the cause of the hypertension.
Yes, sir.
But the way we've been taught in initial education is that there's this mysterious thing called hypertensive crisis that is a pathology in and of itself, but that's not really true. There's always something underlying that's causing it. Is that
correct? That is, yeah, treat the underlying cause, correct. And forgive me, I guess my point to all this is that hypertensive emergency will be a diagnosis that I make in the ER after I have labs, multiple images, and I've done everything else to treat the underlying cause, and I didn't fix or find a problem. If I find the problem, I treat the problem. If I can't find the problem, at the end of the day, I'm gonna say, yep, it's what we call PRES or hypertensive emergency, and I'm gonna treat the blood pressure. But otherwise, I treat the problem. Did that answer it or make it more confusing?
No, it did. It did very good. So other than the critical care flight folks or folks making really long transfers, you really see any point to the beta blockers?
No, I do not in the pre-hospital world. Now, again, talk to your medical director, have that discussion with them. There's always a variance in physician thoughts, but I think there's more harm than good from using the medicines for hypertension that we have at this point in the game. Now, critical care is different, but they also are doing transfers from one hospital to another and have that objective data that can say, oh, yes, you have a dissection, or yes, you have a hemorrhagic stroke, and that changes everything. Just blood pressure management in the emergent setting is dangerous, super dangerous, right?
Yep. Yeah, I tend to agree with you on that one. I don't think that for the most part we should be using beta blockers or blood pressure control pre-hospital. Well, hey, great lecture. Anybody in the room have any more questions or comments? I think we're about out of time. Thanks again to Dr. Ferguson and to Dr. Hereford for some great lectures today. Thanks to Pilcher's Ambulance, Dothan Fire, and Survival Flight for sponsoring us today. Great facility, good crowd. We appreciate everybody participating here in person and online. If you need to get please remember to fill out our attendance form. If you're here live, we've got sheets around with a QR code for you to scan. If you're online, the link is in the Q&A section. If for some ever reason you can't do that, I'll be running a slideshow here for several minutes after we finish. And there'll be a scannable code there. Or if all that fails for you, you can send an email to alabamaemschallenge@gmail.com. Doesn't matter what you say in the email, you'll get an automated response with a link to the attendance form. And remember, the password for the attendance form today is sepsis, the word sepsis. And let's see, where are we going to be again in March?
I think Trustville and then Enterprise.
Trustville and Enterprise. Yep. Second Wednesday we'll be in Trustville. Fourth Wednesday in Enterprise, if I remember correct.
Third Wednesday in Enterprise because we have.
Third Wednesday in Enterprise.
Yeah, so dates a bit strange in March and April because of FDIC and CCTMC.
Gotcha. Got some conferences that are conflicting with our normal schedule. All right. Thanks again, everybody. We'll see you next time.